Equipment Lesson 19 is scatter radiation control. Scatter is the #1 cause of contrast loss in clinical radiography. It does not come from the tube, it comes from inside the patient. And unless you control it, every image you take on thick anatomy will be degraded by it. We cover where scatter comes from, beam restriction, grids, air gap technique, how KVP affects scatter, and how to choose the right control method for the situation. 12 minutes. Scatter originates from Compton interactions inside the patient's tissue. Here is the mechanism. An incoming X-ray photon strikes an outer shell electron. The photon transfers some of its energy to that electron and continues in a new direction, a different direction from the one it was traveling. That redirected photon is scatter. It carries real energy. It can reach the detector, but it carries zero useful anatomical information. When it hits the detector, it adds uniform gray fog to the image, and that fog reduces the visible difference between adjacent tissue densities, which is exactly what contrast is. 3 things increase scatter production. Higher KVP. The Compton interaction becomes more dominant as energy rises, so more scatter is produced. Larger field size. More tissue volume in the beam means more Compton interactions. And thicker anatomy. More tissue depth means more total interactions. The clinical threshold for grid use. Anatomy greater than or equal to 10 centimeters thick or technique greater than 60 kVp. When either of those conditions is met, scatter is significant enough to require active control. At anatomy thicker than 20 centimeters, scatter can exceed the primary beam intensity. At that point, without scatter control, the image is mostly fog, soft tissue margins disappear, and contrast is severely degraded. For control methods, beam restriction, grids, air gap technique, and KVP adjustment. We will cover each one. The scatter production line chart on this slide shows an exponential relationship. As field area increases from 25 square centimeters to 800 square centimeters, scatter production rises steeply, nearly proportionally. Every centimeter you add to the field adds more tissue, more Compton interactions, and more scatter. Beam restriction works by attacking scatter at its source. Smaller field means less tissue irradiated. Less tissue means fewer Compton interactions. Fewer interactions means less scatter produced. And less scatter produced means less fog at the detector, which means better subject contrast. Dose reduction and contrast improvement happen from the same action simultaneously. The regulatory minimum is positive beam limitation, PBL, which automatically limits the field to the image receptor size. But PBL is the floor, the regulatory minimum, not the ARRT goal. Radiographers are obligated to collimate smaller than PBL whenever the anatomy allows. Every exam, without exception, collimation borders visible on all 4 sides of the image is a required image evaluation criterion on the ARRT. If those borders are not visible, the field exceeded the receptor. That is an LAR, a violation regardless of how good the image looks. Beam restriction reduces scatter before it is produced. Grids handle the scatter that has already been produced inside the patient and is now heading toward the detector. The grid is positioned between the patient and the image receptor. It consists of thin lead strips separated by radiolucent interspaces. The lead strips are aligned toward the X-ray tube focal spot. Primary beam photons traveling in a straight line from the focal spot pass through the radiolucent gaps and reach the detector. Scattered photons traveling at angles strike the lead strips and are absorbed. 3 grid performance metrics the ARRT tests directly. The Bucky factor, also called the grid factor, is the MAS multiplier required when a grid is used. 5-to-1 ratio, Bucky factor approximately 2. 8-to-1, approximately 4. 12-to-1, approximately 5.5. Every time you add a grid, you need more MAS, and the patient receives more dose. The contrast improvement factor, CF, is the ratio of image contrast with a grid to contrast without it. Typically 1.5 to 3.0, depending on grid ratio and scatter conditions. That is how much better the contrast is with the grid compared to without. And selectivity, the ratio of primary radiation transmitted through the grid to scatter radiation transmitted. Higher selectivity means the grid is more efficient. More scatter stopped per primary photon passed. The trade-off is direct and unavoidable. Every improvement in scatter cleanup requires more MAS and increases patient dose. Choose the lowest grid ratio that adequately controls scatter for the clinical situation. Use a grid when anatomy is greater than or equal to 10 centimeters, or technique is greater than 60 kVp. Do not use a grid for thin anatomy, extremities, small children, where scatter is minimal and the Bucky factor penalty is not justified. Air gap technique improves contrast without using a grid by allowing scatter to miss the detector instead of removing it with lead strips. Here is the mechanism. When you increase the OID, a gap of air forms between the patient and the image receptor. Primary beam photons travel in a straight line from the focal spot directly toward the detector. They still reach it. Scattered photons exit the patient at angles. As the gap increases, those angled scatter photons increasingly miss the edges of the detector. The result, the ratio of primary photons to scatter photons at the detector improves. Better primary to scatter ratio means better contrast. A typical air gap of 10 to 15 centimeters, 4 to 6 inches, provides meaningful scatter reduction in most applications. The trade-offs are real and must be managed. Increasing OD increases magnification. The magnification factor formula applies directly. Monday to Friday equals SID divided by SOD, and increasing OD decreases SOD. You also get more geometric unsharpness. Penumbra increases with OID. At high OID values, a small focal spot may be necessary to keep blur at an acceptable level. When to choose air gap over a grid. When magnification is already desirable, magnification radiography is a natural fit. When a grid is unavailable, portable work with thin anatomy where a stationary grid is not practical. When to choose grid over air gap, when scatter is heavy, thick abdomen, high kVp. The grid removes scatter more completely than air gap and does not add magnification. This dual bar chart shows two lines running in opposite directions as kVp rises from 50 to 120. Scatter production, the red bars, rises. Subject contrast, the green bars, falls. Both effects happen simultaneously. This is the fundamental kVp trade-off in radiography. At low kVp, 50 to 60, the photoelectric effect dominates. Tissues of different atomic number absorb the beam very differently. The difference in transmission between bone and soft tissue is large. High subject contrast. Short scale, stark black and white. Less scatter produced, but more patient dose, because lower kVp photons are absorbed more heavily in tissue and more MAS is needed. At high kVp, 90 to 120, Compton scattering dominates. More scatter is produced. Less differential absorption between tissues. Lower subject contrast, longer grayscale. But patient dose can be reduced because penetrating photons require less MAS. The optimal clinical strategy for thick anatomy in digital radiography. Combine high kVp with a grid. High kVp reduces dose. The grid removes the increased scatter that high kVp produces. The result, adequate contrast at minimum dose. This is the gold standard for abdomen, spine, and chest, and a critical digital imaging point. At high kVp, window and level adjustment after acquisition can restore display contrast. The underlying subject contrast is lower, but digital post-processing compensates. This is why high kVp technique is specifically preferred in digital departments over film-era lower kVp approaches. The comparison table on this slide puts all four control methods side by side. Lock in what each one does, when to use it, and what the trade-off is. Collimation reduces scatter produced at the source. The best first-line tool, always use it. Improves contrast and reduces dose from the same single action. No downside when used correctly. Use it on every exam. Grid. Removes scatter that has already exited the patient. Significantly improves contrast. Increases patient dose by the Bucky factor. Use when anatomy exceeds 10 centimeters or technique exceeds 60 kVp. 8:1 is the standard for general radiography. Air gap. Scatter misses the detector due to divergence. No dose increase from grid factor. Causes magnification, the primary trade-off. Best when magnification is acceptable or a grid is not available. Low kVp. Reduces Compton scatter by shifting interactions toward the photoelectric effect. High contrast, short scale. Higher patient dose because more MAS is required. Best for extremities and fine bone detail, where low dose is not the primary concern. And high kVp combined with a grid. The balanced approach. High kVp lowers dose. The grid restores contrast lost to the increased scatter. The gold standard for thick anatomy in digital radiography, abdomen, pelvis, and spine. For clinical applications to lock in before the practice questions. First, clinical scatter thresholds. No scatter control needed when anatomy is less than 10 centimeters thin, technique is below 60 kVp, and the patient is small, children, extremities. Adding a grid to thin anatomy multiplies dose for no diagnostic benefit. Grid required. Anatomy at or above 10 centimeters. Technique at or above 60 kVp or large field size. These are the ARRT thresholds. Know them. Both grid and tight collimation. The combination for maximum scatter conditions. Large adult, high kVp, large field. This is your thick abdomen, your barium study, your interventional case. Second, collimation to anatomy, not to the image receptor. PBL limits the field to the receptor size. That is the minimum. For an AP lumbar spine, collimate to the vertebral column margins. For a knee, collimate to the joint. Every centimeter of field reduction improves contrast and reduces dose. Third, contrast improvement factor by grid ratio. No grid. CF equals 1.0, baseline. 5:1, approximately 1.5. 8:1, approximately 2.0. 12:1, approximately 2.5. 16:1, approximately 3.0. Higher ratio, better contrast, more dose. Always choose the lowest ratio that does the job. And fourth, the decision tree. Always collimate first, that is free contrast and free dose reduction. Then ask, is scatter still a problem? If yes, add a grid. Is magnification needed? Then use air gap instead of grid. Is the patient very thin? Lower kVp gives more contrast without a grid. Is the patient very thick? High kVp plus grid is optimal. Apply these decisions systematically and your scatter control is correct every time. 3 scatter control questions. These are clinical scenarios formatted exactly as the ARRT presents them. Think through the reasoning before the answer appears. The answer is C. Add an 8:1 grid to remove scatter. At 22 centimeters AP and 80 kVp, this patient exceeds both the 10 centimeter thickness threshold and the 60 kVp threshold. Scatter from Compton interactions in that thick abdomen is the direct cause of the poor soft tissue contrast. Adding a grid removes that scatter before it reaches the detector, dramatically improving contrast. Increasing MAS makes the image brighter but does nothing to the fog. It does not remove scatter. And changing SID does not address the scatter problem. The grid is the correct tool. The answer is B. More tissue volume in the beam produces more Compton scatter that reaches the detector as fog. Field area increase from 100 to 400 square centimeters adds 3 times the irradiated tissue volume. More tissue means more Compton interactions. More interactions means more scattered photons traveling toward the detector. More scatter at the detector means more fog, and fog reduces the visible difference between adjacent tissue densities. That is how a larger field directly degrades contrast, and it is exactly why collimation simultaneously improves contrast and reduces dose from the same single action. The answer is B, higher contrast and increased magnification. Air gap technique improves contrast because off-angle scattered photons miss the detector as OID increases. Primary beam photons traveling directly from the focal spot still reach the detector, so the primary to scatter ratio improves and contrast improves. But increasing OID always increases magnification. Magnification factor equals SID divided by SOD. As OID increases, SOD decreases, and Monday to Friday increases. The trade-off is accepted in specific applications: skull work, magnification radiography, where magnification is clinically useful. For routine imaging, a grid is preferred because it improves contrast without adding magnification. Lesson 19 complete. You covered Compton scatter as the source of image fog and contrast degradation, beam restriction with the scatter versus field area chart, grids with the Bucky factor and selectivity metrics, air gap technique and its magnification trade-off, KVP effects on scatter with the dual contrast chart, and the complete scatter control comparison table with clinical decision rules. Scatter control is not optional. It is the primary technique tool for maintaining contrast in thick anatomy. Collimate on every exam. Every centimeter counts.